Okay, hello, and good evening from the UK. It's a pleasure to have everyone dialing in for this webinar. My name's Anil Bangu. I'm a colorectal surgeon in the United Kingdom, and I'm the chief investigator of the COVID Surge Collaborative. So we've really launched this webinar tonight is in response to the Omicron wave that's hit the world, and to give everyone updated information and really background for surgeons on what Omicron is and what we need to do about it. And what's the best way to do that? So I thought that the best way was actually to invite some non-surgeons to talk to us. So we've got some public health experts joining us tonight. So firstly, Dr. Gabrielle Morley. Gabby, lovely to speak to you. Thank you for joining us tonight. How are you?
Hi, Anil. Thank you for the invite. I'm very well. I hope you are too.
Thank you. So Gabby, you're a public health doctor, and I think back in the first wave, you were involved in some of the first testing that was done for COVID. Is that correct?
Yes. So I was based at the University of Birmingham at the time. That's in the UK, and as everyone probably remember all too well, that back in late March, early April 2020, not much was known about COVID, and it was considered really quite dangerous to handle the virus in the laboratory. So they required category 3 level containment for neutralizing the virus prior to PCR testing. So I was category 3 trained due to previous work with mycobacterium tuberculosis. And so I helped neutralize the virus, and we did some of the first PCR tests, which was very useful at the time.
And since then, have you been involved in the public health response to COVID within the community?
Yes. So since then, I was working at Public Health England in the UK, and was essentially working on sort of preventing outbreaks in workplaces, schools, and that was particularly important during September of last year, or 2020 in particular.
Okay, good. So we'll come back to you for the first talk, but I must also introduce Dr. Dmitry Nepogodiev. Good evening, Dmitry.
Hi, good evening.
So Dmitry is another public health doctor. He's also one of the principal investigators of the COVID Surge platform. I would ask the audience if anyone doesn't know him, because he's become quite famous in surgical circles. He's sort of dual trained in surgery, but is now a public health expert. So Dmitry, your COVID Surge background doesn't really need any introduction. You know, we were there from day one launching COVID Surge again back in March. And we sort of had some late nights getting that into the Lancet, didn't we?
Yeah, that was, well, almost 2 years ago. It's scary to think, isn't it?
And similarly, although you've been doing the COVID Surge work, you've also been involved in the Public Health England response to COVID in the community.
Yeah, that's right. So my day job is working in local government in Coventry, which is a city in the UK. And my role there is to support organisations and settings with COVID outbreaks to see how we can help them to reduce the number of people getting infected.
So it's a pleasure to be joined by both of you. And I think it's really unique to have public health physicians who are involved in day-to-day care of communities joining us. So thank you both very much for your time. Our first talk will be from Gabby. So she's going to give us some information on Omicron for surgeons. So that's a good chance for you to get your slides up, Gabby. What I would say as we go through all this, and I'm sure everyone knows this already, is that we're really doing this for our patients. And so it's great to have all these publications. It's great to be talking to big groups of people. But I'm aware, just like you, we're doing this to improve the quality of care we give to people and make sure that the in-hospital operations and surgeries that we offer people are as safe as possible. And we're going to stick close to that mission. So, Gabby, I'm going to hand over to you for the first talk. If you're ready to go, please.
Thank you, Anil. And thank you to the organisers for inviting me. So I'm going to discuss Omicron and what the current evidence we have about this new variant and what the threat of Omicron is to surgery. So, as you're probably aware, SARS-CoV-2 is the virus that causes the disease COVID-19. And it is just a length of RNA which is wrapped in a lipid membrane that is interspersed with proteins, including the spike or S protein, which projects from the viral surface. And these spike proteins bind to ACE2 receptors on human cells through the receptor binding domain, which is shown in the image in the bottom right of the screen. Inside the host cell, viral replication is able to occur, and just by chance, mutations can arise. These mutations are usually small and irrelevant and often disadvantageous to the virus. However, some mutations can make the virus more transmissible, virulent, and or immune evading. And those group of coronaviruses that share the same mutations are called a variant, a different version of the SARS-CoV-2 virus. Some of these are variants of interest, and some of them are designated as variants of concern by the World Health Organization, depending on the risk to the human population. Coming to Omicron, so Omicron was designated a variant of concern by the World Health Organization after it was first identified back in November of 2021 through the genomic surveillance in Southern Africa. And some of the first cases were detected in South Africa and Botswana, but it then spreads internationally and has rapidly become the dominant strain in many countries. So looking at the sort of structural biology just quickly of Omicron, it has a large number of mutations relative to previous variants. And many of those mutations haven't been seen before. And many of them were concerning because they were in the S protein, in particular, the receptor binding domain. And it is that receptor binding domain which is able to allow the entry of SARS-CoV-2 into the human cells through interacting with the ACE2 on the surface. Many neutralizing antibodies have been developed to the receptor binding domain through vaccination or previous infection. And so it was feared that those mutations in Omicron, which you can see highlighted in the image on the right in red, would mean that this variant is able to evade the immune response. And actually, that is what some of the data has shown. It appears that Omicron has evolved for not only escaping the antibody response to a certain extent, but also increased affinity to the ACE2 receptor, and that makes it particularly troublesome. So in terms of the characteristics of Omicron, the data that we have got at the moment show that it is higher in infectivity. So it has a faster doubling time, and it is more transmissible than the Delta variant. Further, however, the severity of Omicron appears to be lower. So it seems to have lower severity, with a 1/3 reduction in risk of any hospital attendance compared with the Delta variant. So that seems to be quite good news. There is also approximately a 2/3 reduction in risk of more severe endpoints, such as formal admission or death. But that is balanced against the fact that, as I've mentioned, there is a level of immune evasion. So past infection does protect up to 85% of individuals against hospitalization, but there is minimal protection against infection with Omicron. Because the estimated risk of reinfection with Omicron variant is 5.4 times greater than Delta. So it really is evading the protective antibodies that people have developed through previous infection. Vaccination, however, does offer some protection, especially after a booster or a 3rd dose, which we'll touch on a little more later. And the World Health Organization has indicated that international spread is apparent, and that very soon more than half of Europe could be infected with the Omicron variant. So it is something that we need to be aware of, and that we should have some level of concern about. In terms of what symptoms you should be looking out for when patients present to you and may be suspected of carrying COVID or the Omicron variant, well, of course, they may be asymptomatic, but what is also been shown in the ZOE study, which is a study in the UK, Omicron infection has been associated with cold-like symptoms, and the top 5 symptoms include running nose, headache, fatigue, sneezing, and sore throat. And so that's quite interesting, really, because it compares to the previous 3 cardinal symptoms of fever, cough, and a loss of sense of taste or smell, which only 50% of Omicron positive individuals experience, and that's a lot fewer than Delta cases. And actually, sore throat was reported far more often by individuals testing positive for Omicron, and that compares to Delta, where far fewer people were stating that they had a sore throat. In terms of diagnostics and treatments, well, positively, the PCR tests and rapid antigen detection tests still are able to detect Omicron infection, and treatments still are effective for preventing Omicron from causing severe disease. So those include immunosuppressants and antivirals. However, Omicron does appear to be at least partially resistant to the majority of monoclonal therapeutics, which were neutralizing through binding to the spike protein on the virus. And so unfortunately, many of these monoclonal antibodies can't be used now when an individual has Omicron. And that will have repercussions for individuals with severe COVID-19. In terms of vaccine effectiveness against Omicron, well, as we know, the highest infection risk is in those who were previously uninfected and those who were unvaccinated. So vaccines still remain a really important tool in the arsenal. However, their effectiveness is lower for Omicron compared with Delta. In terms of protection against infection, unfortunately, after about 20 weeks, 2 doses of vaccination means that the protective effect has pretty much waned. A booster dose, however, can increase that protection to around 65 to 70%. But again, this protection does wane over time. On the other hand, the vaccines are much more protective against severe disease and hospitalization. So 2 doses gives protection of up to 55%, but 3 doses really does boost that protective effect and up to 90% protection against severe disease and hospitalization. So I think the message really is that although vaccine effectiveness is lower, they do remain effective, and the 3-dose regime is optimal. So how is Omicron spreading? Well, I've just taken this from the UK Health Security Agency, and it really just illustrates how Delta in purple was dominant over the last 6 months or so. However, since the introduction of Omicron has swept through the country and pretty much taken over. And I think that will be mirrored in other countries. And again, just looking globally, we can see that with Omicron occurring the end of November, early December, there was a huge increase in the number of reported cases and unfortunately in the number of deaths. And that was seen across many different regions in the world. So what is the status of Omicron now? Well, I think the UK is quite an interesting and a good example because it was hit quite early on with Omicron. And what we've seen is that there was a rapid increase in the number of people who were testing positive for COVID and who had Omicron in the bottom left of your screen over the month of December and into early January. And the Office of National Statistics survey indicated that up to 1 in 15 individuals in the UK, it's really quite a high proportion of individuals were infected and had COVID-19 at that point. But it appears now over the last few days, or at least the last week or so, that there is a reduction in the number of people testing positive, which indicates that perhaps we have seen the peak. Looking at deaths and patients admitting, obviously, that lags behind the number of people testing positive. And we did see a rapid increase in the number of patients admitted to hospital, and unfortunately those dying within 28 days of a positive test. Again, that does seem to be plateauing, but I think it's important to mention here that the proportion of deaths that have occurred with this wave of Omicron has been substantially lower than that seen with the initial SARS-CoV-2 variant. And so it indicates that all of the measures that have been put in place, particularly vaccinations, have had some protective role to play. So what is the threat to surgery? Well, as I've illustrated, unfortunately, Omicron is highly transmissible. It has immune evading properties, which means there is limited protection against reinfection, which means there is a high risk of a large burden of Omicron infections in any population. That high prevalence of infection puts pressure on healthcare services, which I'm sure we're unfortunately all too familiar with, because we need to treat those who are sick with Omicron. We need to isolate those who test positive for Omicron but require treatment for other conditions. And then, of course, there's Staff shortages because our staff are human too and can succumb to sickness or require to be absent through isolation. And as has been seen in the UK in particular, the diversion of healthcare activity to support vaccination capacity has meant that other healthcare services have been stripped of the opportunity to provide treatment. And finally, staff fatigue, which shouldn't be overlooked. Is there a silver lining with Omicron? I mean, it's hard to really say, but the few positives that can be drawn are that Omicron is intrinsically less severe, and that has been shown through numerous different groups and studies. Non-pharmaceutical interventions, including masks, social distancing, ventilation, still have protective properties. Our diagnostics remain effective. We do have multiple treatments which remain effective. And vaccines, particularly in conjunction with the booster dose, offer protection against severe disease and hospitalization. And they do also, albeit to a lesser extent, reduce the risk of infection with Omicron and the risk of transmission. So to summarize, the main messages are that vaccination and boosters are effective against severe disease. That does need to be balanced against the fact that Omicron is highly transmissible, has immune evading properties, and is able to reinfect individuals. And unfortunately, protective immunity to Omicron wanes over time, which will be important to remember, particularly as we go into the spring and the summer months. And so different experience will likely experience slight differences in the way that Omicron presents nationally due to their different demographics and immune backgrounds. But it is likely that high levels of Omicron infection will occur, and this will impact hospital services, and this therefore needs to be anticipated and prepared for. So that's the end of my whistle-stop tour of Omicron. I'll pass back to Anil now and stop sharing my screen. Thank you.
Brilliant. Well done, Gabby, and thank you very much. And I think you've really reflected COVID Surge's ethos there, because you've given a very factual, data-driven presentation, which is exactly what we need and what we're looking for. So we'll save the main discussion for later, but that one question has come through from Mohit Bhatia, who said, and I think you sort of answered this in your summary, but let's revisit it. Do you think the vaccination programs have made a difference in curbing the Omicron threat, or do you think it was a low-risk variant by nature?
Yeah, thank you, Mohit. That was a really excellent question. So the vaccines offer protection. The data shows that. The more doses, so the third dose, increases that protective effect. So it is difficult to say how Omicron would have played out without the vaccination, but it is almost certainly the case that the vaccinations have provided protection and have reduced the risk of individuals presenting to hospital and having severe disease. That being said, Omicron is less severe compared with Delta, but it still has a huge capacity, particularly in those who are unvaccinated, to cause severe disease. And therefore, if there was nobody vaccinated and coupled with the fact that it is so highly transmissible, we would see absolute huge pressures on healthcare services. So I think the overall message is we can be slightly relieved that it is less severe, but we shouldn't rest on our laurels. And I think the vaccines have been proven to be effective, particularly with a booster dose. And that is the primary wall of protection against this variant.
Okay, brilliant, and a really good comprehensive answer. Thank you very much. So I'm going to move over to Dimitri next. Dimitri is going to talk to us. So Dimitri, if you start sharing your slides, please. So while you're doing that, firstly, could you launch the first of the poll questions for me, please, Melody? So the first question, there are only two short questions. We're interested to see if people have really laxed their rules, or if people are keeping their consistent rules around bringing patients in for elective surgery. So are you currently testing patients for SARS-CoV-2 before surgery? So please pick one of the choices on the screen ahead of you, and we'll continue. Also, in the meantime, please keep sending your questions through via the Q&A box, and we'll answer them, and we'll also use them as part of the discussion after Dimitri's talk. So Dimitri is going to talk to us about his latest publication and what this data means to us and how we can use it to plan into the future. So Dimitri, I'm passing over to you.
Well, thank you very much, Anil, and thank you to everyone who's joined from across the world. It's a great pleasure to be able to share our data with you. So the first question I wanted to look at was, how will Omicron impact elective surgery? As Gabriella has already mentioned, there's going to be a large number of patients and people around in communities developing infection. So what's the likely impact? We know that over the past 2 years, up to 100 million elective surgery slots have been lost worldwide due to cancellations related to the pandemic. Over the coming weeks, as Omicron spreads in communities, it's likely that the number of patients in hospital with COVID-19 will increase. We wanted to look at what's the likely impact of that on elective surgery. So what we've done is we've used routine NHS activity data, which was available online, and we've plotted on the chart that you can see on the right for each month from September to July, September 2020 to July 2021, the number of patients who were in hospital at any one time, on average, against the reduction in elective activity that month compared to the same month in 2019, pre-pandemic. So you can see that as the number of patients in hospital increases, there's a trend towards a decreasing rate of elective activity, more cancellations, fewer operations being done. So we've then used a statistical model to try to generalize that relationship, which is what you can see on the right of your screens now. So essentially, we can use the statistical model to estimate what the elective activity is likely to be at any number of patients in hospital in England with COVID-19. So based on the current number of patients, which is around 16,000 patients in hospital in England with COVID, we can estimate that we think elective activity is likely to be reduced by approximately a third compared to what we would have expected at this time of year pre-pandemic. And that means we're probably doing about 26,000 fewer operations each week than we would normally be doing. And that obviously adds onto the existing backlog. So in the UK alone, our backlog is well over 2 million operations over the course of the pandemic. So this is week by week, we're increasing that backlog. We've developed a real-time tracker. So if you go on the link on the slide, you can see our live estimates for what's happening today based on the reported number of patients in hospital. So it's a useful tool to be able to understand the likely impact of the pandemic at any given time. And this data has been peer-reviewed and published in The Lancet this week. So if you're interested in reading the detailed methods, you're welcome to do so. The next question I wanted to look at is, what do we know about the significance of COVID based on the evidence we gathered in 2020? And I think in summary, we can say that data from the early pandemic is that perioperative COVID-19 is associated with both increased mortality and increased postoperative pulmonary complications. Moreover, perioperative patients, so patients who develop COVID-19 around the time of surgery, are a particularly vulnerable group. So I've just got three bits of evidence that I'd like to share with you. Firstly, from our first publication in The Lancet in June 2020, this bar chart breaks down the 30-day mortality rate in patients who develop perioperative COVID-19 by different subgroups. And what you can see is that whilst the overall mortality rate was 24% in patients with perioperative COVID-19, in fact, the mortality rates were very high across all subgroups. So this finding wasn't just a selection bias, because even younger patients having low risk surgery were having high mortality rates. So that's the first hint that COVID-19 is a significant problem. The second piece of evidence I'd like to share is on the left of your screens. This is taken from our publication in BJS, looking at modeling the impact of vaccination. And essentially, we've compared patients who did have perioperative SARS-CoV-2 versus patients who did not have perioperative SARS-CoV-2. And we've then adjusted the differences in mortality between those two groups. So we've adjusted for factors like sex, the urgency of the surgery, whether they were having minor or major surgery, the ASA grade, the cardiac risk, and other factors. What you can see is that regardless of the age of the patient and whether they were having either cancer or non-cancer surgery, in each case, the patients who had perioperative SARS-CoV-2 had higher 30-day mortality than the patients who did not have perioperative SARS-CoV-2. So you can see that in the older patients, the increase in mortality was particularly high, between 10 to 15%. This last bit of evidence is on the right of your screens, and this is looking at the data from the first wave that we've collected. In the blue bars, you can see what the 30-day mortality was in our surgical cohort of patients during the first wave. And you can see that the mortality rate increases with age. The orange bars show data that I've extracted from available data sources for overall COVID-19 mortality in the UK. And you can see that the blue bars are generally higher than the orange bars, meaning that the surgical patients had higher 30-day mortality than the general population who had COVID-19. The exception is in the patients aged 70 and over, and that probably reflects selection bias that we probably don't operate on some of the very frail older patients who are having COVID-19. But certainly you can see that, for example, in 40 to 49-year-olds, whereas the mortality in the general population was quite low at 2%, in the surgical patients it was 9%. This is why I say the surgical patients are a particularly vulnerable group when it comes to COVID-19. There was a question in the chat about incidental COVID. So this is the idea that there are patients who will have picked up COVID-19, SARS-CoV-2 infection in the community, and they happen to then have probably an operation of some sort. They get tested preoperatively and they test positive for COVID-19, even though they don't have any actual symptoms. They're completely asymptomatic. And this is being called incidental COVID. In London, that might account for 30 to 40% of patients in hospital who have tested positive for COVID-19. They're patients who are actually asymptomatic in terms of COVID, and they're in hospital for some other reason. What we've taken here is the data from Surge Week, and this is completely new data we're sharing with you. So we've taken the data from Surge Week, where we had data on patients who didn't have SARS-CoV-2, patients who had incidental SARS-CoV-2, and patients who had symptomatic COVID-19. And we've adjusted the 30-day mortality rates for all those factors I've described previously to compare the mortality rates between these different groups. And you can see that there is an increased risk with an odds ratio of about 1.5 in the patients with incidental SARS-CoV-2, which is statistically significant. So even though they've tested positive despite having no symptoms, those patients have an increased risk of death if they are operated. And the same pattern we can see for 30-day postoperative pulmonary complications. So again, there's a statistically significant increase in risk with an odds ratio of about 1.4. Those risks are less than if the patients were symptomatic, but there's still increased risk compared to baseline. So what can we do to reduce risk in patients having surgery during the Omicron wave? The first thing I would suggest is preoperative testing. This publication from BJS used the COVID surge cancer data from the first wave to compare postoperative pulmonary complication rates depending on whether patients underwent testing or had a preoperative SARS-CoV-2 swab. And you can see that actually, regardless of what the community SARS-CoV-2 rate was, there was a reduction in pulmonary complications in the patients who were screened with a SARS-CoV-2 swab. Now, bearing in mind that the community rates today with Omicron will be far, far higher than anything that occurred in the first wave, and therefore the benefits of screening are likely to be increased. Some health systems are, and that includes in fact in England, are moving towards using rapid antigen tests rather than PCR tests. And although these have lower sensitivity in terms of they're more likely to miss COVID infection than a PCR test. So what we would suggest is use a PCR test if that's possible. But if your health system is using rapid antigen tests, then we would suggest using those. And that's better than doing no testing at all. So do test if possible, PCR if you can. On the other hand, this publication, BGS, showed that there was no benefit to preoperative CT scanning. So we would not recommend CT scanning for screening patients. So what if a patient tests positive when we preoperatively screen them? Our publication from the surgery data study in anesthesia quite clearly and I think robustly showed that patients who are within 6 weeks of a positive test or a diagnosis of SARS-CoV-2 are at increased risk of both postoperative mortality and postoperative pulmonary complications. That risk returns to baseline if patients are operated beyond 7 weeks. So what you can see on the screen now are adjusted mortality rates. So those are percentages, adjusted mortality rates. And you can see that if we wait 7 weeks or longer, then the risks return to baseline. But if we operate sooner, patients will be at increased risk. So we would suggest, where possible, delaying. And once we do decide to operate on the patient, providing a COVID-19 free surgical pathway is really important. This reduces the risk of postoperative SARS-CoV-2 infection being acquired in hospital, almost halves that risk. It reduces the risk of postoperative pulmonary complications, more than halving that risk. And it reduces the risk of postoperative mortality. And this was very robustly demonstrated in our publication in the Journal of Clinical Oncology. So I know that some hospitals have reverted to treating their surgical patients on, in a normal way, but we would still advocate that particularly during a wave of infection, it would be beneficial to continue utilizing COVID-free pathways if it's possible. So in summary, Omicron will probably be associated with a reduction in elective surgery activity and an increase in the risks of patients who are having surgery, so increase in mortality and increase in pulmonary complications. But we can mitigate these risks by testing patients before surgery and delaying surgery when possible in the patients who test positive, and by maintaining COVID-free surgical pathways. Now, I haven't talked about vaccination, but that is also a very, very important tool. So we should be vaccinating, ideally double vaccinating patients 2 weeks before they undergo surgery. And that's because in the general population, there is a substantial reduction in both the severity and the likelihood of death in patients who are vaccinated. And there's some reduction also in patients who've had previous SARS-CoV-2 infection. And so we think that vaccination is very likely to substantially reduce perioperative risk, but there's actually very little data to support this at present. And so that's why we set up COVID Surge 3 to collect real-world data during the Omicron wave, so that we would gather new data from this era when some patients are vaccinated, when some patients have had previous infection already, and when we've got new variants, including Delta and Omicron. Because there is a risk that our previous data is becoming a bit of out of date because it's from the previous era. So that's why we'd really enjoy working with you to develop this new evidence base to support safe surgery in 2022. I think research has been one of the most powerful tools in controlling the pandemic, and I hope that we can continue this collaboration. So just to very briefly summarize, COVID Surge 3, very similar to our original COVID Surge study. It is collecting data just on the patients who have tested positive for SARS-CoV-2. So it should be a low burden, low number of patients in most hospitals, just the patients who've tested positive, either in the 7 days before or 30 days after surgery. We're including all specialties, adults and children, surgery for any reason, surgery under general or regional or local anesthetic. So it's very inclusive, everyone can get involved. The patient inclusion window runs until the 28th of February, and then there's 30-day follow-up. So if you'd like to get involved, then please visit our website, globalsurge.org/COVID-Surge3, and we'd be very pleased to get you involved. We've already got just over 1,000 hospitals registered to participate, and almost 350 patients have been entered into the database so far. So we think this will be a very important study to inform surgical care during the next 12 to 24 months. So thank you very much.
Brilliant. Well done, Dimitri, and thank you very much. And another data-driven talk. So we've got about 10 to 12 minutes, and we've got quite a lot of questions, so I'm going to get stuck in. So, Dimitri, one of the most common questions coming in from everyone is, what do I do with a patient who has a SARS diagnosis? And I think that's to be expected, I guess, as Omicron's become so common across the population. So I'll let you answer, and then I'll give my comments too. So what do we do with a patient who has a positive swab? I'm going to give you two scenarios there. Number one is a cancer patient, an elective cancer patient. But number two, can you imagine a young patient, a 30-year-old bloke who's got appendicitis and they're sitting in hospital? So what's our current data to address these patients?
So looking back at the data we have available, what do we know? First of all, patients who have tested positive for SARS-CoV-2 are likely to be at increased risk of complications and even mortality. However, that risk is not even, in the sense that there are some groups of patients who are very high risk. So older patients having emergency cancer surgery are at high risk, whereas patients who are younger, for example, under 40 years of age, having relatively smaller operations are at lower risk. We think that vaccination is likely to significantly reduce their risk, but we need to sort of see the evidence for that in the surgical population. The reason for that, because there is the evidence that vaccination is beneficial, is probably the single strongest evidence base for any intervention in the world ever. But the reason in surgical patients is that we know this is a more vulnerable group, and that although vaccination is likely to be highly beneficial, we don't know the extent to which they might still run into problems, even though vaccinated. So going back to your scenarios, young man with appendicitis, we would probably say we should have a joint decision with that patient, discussing the options for surgery versus non-operative management. But surgery is probably a good option for that patient. They're probably relatively low risk. You can use a COVID surgery risk calculator to get a sort of a more evidence-based risk for that individual patient. For the cancer patient, clearly it depends on the specifics of their cancer and whether a delay is feasible. Particularly if they're not vaccinated, it may be worth delaying and having that discussion with that patient.
Great. And so I've given the same sort of answer. If someone has appendicitis, if it's really early appendicitis and they're beginning to settle, I'd give them a trial of antibiotics. This isn't a COVID positive patient. I think if the patient was worsening or they had peritonitis, I would take them for an operation. But in that situation, personally, I would use enhanced PPE for myself, and I would give strong consideration to an open operation. So I'd be looking to perhaps minimize the risk for everyone in terms of the laparoscopy and aerialization. And although there's not clear data there, it's a reasonable step to take. Gabby, I'm going to ask you a question. This is a tricky question. So several people have come through and said that Dimitri's highlighted that Omicron in the Lancet paper has led to the loss of elective capacity, which I think, that reflects all of our experiences. Preparing for the future, do we need to be prepared for future variants? Do you have any feeling or any knowledge about whether variants are likely, or is it too early to say?
Thanks. I'll just get out my crystal ball and see. No, I think, look, it's nature, it's evolution. There's going to be more mutations, whether those cause further variants of concern or whether Omicron will completely sort of dominate and become the virus which sticks with us for, or the variant which sticks with us into the long distant future, making it sort of endemic and ending the pandemic is difficult to say. What is likely is that there will be more mutations, but whether those have an impact on humans and an impact on the way in which we can conduct our healthcare services will only time can really tell.
No, okay, and I think the message is we should probably make sure that our elective services are better prepared going forward than they were perhaps in late 2019, early 2020. I'm going to step back a little bit. I'll give an answer. There's still questions coming in about the 7 weeks in elective surgery. So if you have a cancer patient who tests positive just before their operation, my practice is I would be looking to delay that patient for at least 7 weeks. That is based on the best available data that we have published so far. Going forward, the COVID Surge 3 study that Dimitri's leading will very quickly give us data around whether that 7 week delay can be reduced in selected patients during the Omicron era. No one in the world has that data yet. It may be that we can look to reduce that 7 weeks. My practice is that I would prefer to wait for the data. So as soon as we get a signal from the data and we're constantly analyzing it, this is what we call near time real data. We will be looking to launch it through another webinar, through publications, really to support your practice as soon as possible. I am aware that waiting 7 weeks for another 7 weeks for cancer surgery is quite upsetting for patients. So anything we can do to reduce that, we will try and provide you with that data. A question for both of you that's come through. In some countries with an absence of complete and regular testing, in terms of vaccinations before elective surgery, so we'll go to Dimitri first. Is it, as far as we know, is it safe to recommend a vaccine before elective surgery, whether that be first dose, second dose, or booster. So if I see a patient in my clinic, I'm scheduling their operation for, let's say, 3 to 4 weeks. Can I send them down the road, down the corridor for their vaccination?
There's certainly no specific risks with vaccination if this is done 2 weeks or more before surgery. There's no specific evidence of risks of vaccinating somebody the day they're going to have an operation. However, we know that it takes about 2 weeks to get the most benefit from being vaccinated for the immune response to develop. So if patients are going to be vaccinated, ideally it should be 2 weeks before surgery. But there's no risk of, there's no evidence of an increased risk from the vaccine itself.
And Gabby, does that fit with your, well, I'll ask you a slightly different question. If we're seeing patients in clinic, surgical patients in clinic, who aren't necessarily going for an operation, so we see quite a lot of patients who aren't going for operations. We see them for other reasons. We see them after surgery. We see them and decide to treat them without an operation. Do you think the surgeon has a responsibility there to be routinely recommending vaccination to our wider community of patients?
I think the short answer is yes. I think it is all of our responsibility to recommend vaccines which have been proven to be effective for the individual, but also on a societal level for preventing COVID-19 disease. So I think that the importance probably can't be understated that vaccines should be recommended. But then obviously different individuals will have their own reasons for taking the vaccine, and that would need to be discussed at the individual patient level.
Okay, I agree, and thank you. We're going to begin to wrap it up there. There's still quite a lot of questions left over. I think what we might try and do is gather those questions. And Dimitri, I wonder if we can put together some form of, not quite newsletter, but summary of the questions and answers, because there are definitely, if everyone can see the questions, there are themes coming through. There are themes about the issues around the 7 weeks and waiting. There are themes around vaccinations. There are themes around critical care and more frail patients. And I think some form of fact sheet with the data that we could look to circulate to all of the registrations and participants. Dimitri, do you think, is that something that would be useful, and can we work on that?
Yeah, definitely. I think it would be great to address everyone's questions. I think, as you say, there's some clear themes that we can hopefully help people with.
So what we'll do then, we'll take all of the questions that have been written online and we'll answer them in a fact sheet. If you do have any further questions that you haven't had the chance to type through, or you'd like to think of, if you can email me, I'd be delighted to gather those questions, and we will try and generate a fact sheet as soon as we can. I'd be interested to hear people think that's useful, and whether we need regular fact sheets going around at a global level. But otherwise, we're going to draw a line under it there. Please do take part in the COVID Surge 3 study if you haven't already. We will be constantly looking at the data to see if there's anything we can release as early as possible. We don't quite know how many patients we're going to end up with. Someone's commented that will we have the power to assess the 7-week delay issue? We hope so. We hope we can pick up signals at least that we can make more firm recommendations from. So I'm left to thank you very much, Gabby, for joining us. Thank you very much, Dimitri. Thank you for the work you've done in the communities. And I look forward to creating that fact sheet, because I think actually that will go beyond the participants and we can get that out to 25,000 surgeons around the world. Thank you both very much for joining us, and everyone else have a good evening and a good day wherever you are.
Thank you.
Bye-bye.